Hi guys, Dr. Houlihan here. Today I want to bring you guys some information that is super important for the scoliosis world to know about in case you did not have the opportunity to attend this event in person or virtually. I'm going to be presenting my notes on the 9th Annual Pediatric Spine Symposium presented by Columbia University that took place this year in June in New York City. I know there's only a niche demographic for whom this information is going to be applicable, but for you guys out there, I want to try to bring this to you at no cost to consumer because you need this information. It can literally change the course of yours or your child's life. So let's get right into it. The first study they talked about was about casting. What they found is that earlier is better with casting. If you look at the data, they found a 75% cure rate if the casting was initiated with the child under 18 months of age. At every group up from that, the cure rate goes down dramatically. So between 18 and 36 months, it's at 33%. For 36 to 48 months, the cure rate is 23%. And then from 48 months and upward, the cure rate is only 9%. So if you have an infant with scoliosis, please try to get them in a cast before age 2. This next one is about vertebral body tethering, which is a new procedure that has been emerging in scoliosis treatment. There's sort of a lot to unpack with this slide here, so you can pause it and read through it if you need to, but essentially they found that tethering has higher complication rates than fusions does. It works best on lumbar curves. It's best if the curve is very flexible. Another thing to note is that there is a very long learning curve for the surgeons to become effective with the tethering procedure. So if you do go for tethering, make sure you have an experienced surgeon. This next one is very important for establishing the threshold effect that occurs at about a 30-degree Cobb angle. I'll blow these images up so you can see them one at a time. So this first one is looking at the probability that a curve will reach 50 degrees Cobb angle based on the Cobb angle and the Sanders stage. So let's go to Sanders stage 3. In just a few slides here, we'll talk about why we know that that is the stage where the period of maximum progression or the most rapid growth will usually occur. So if you look at a Sanders stage 3 and you go down the chart to a Cobb 25, there's only a 29% chance that that curve is going to reach 50 degrees. However, if you go to a Sanders stage 3 and you go down to a Cobb 30, there's a 100% chance that that curve is going to reach 50 degrees. We see the same sort of threshold effect in the other image on this slide too. So once again, let's look at the peak height velocity at a Sanders 3 to 4. These numbers that you're looking at are the success with non-operative treatment. So at a Sanders stage 3 to 4 with a Cobb angle between 20 and 29 degrees, there's a 94% chance of success with non-operative treatment. However, with the same Sanders stage, if you go to a Cobb angle between 30 and 39 degrees, the chance for success with non-operative treatment drops down to 76%. And if you go to a Sanders stage 3-4 and you go to a Cobb between 40 and 49, the likelihood of succeeding with non-operative treatment drops all the way down to 22%. Essentially, the likelihood of success with non-operative treatment drops dramatically if the Cobb angle is 30 degrees or above at that period of maximum progression. This next slide sort of builds on that and talks about the likelihood of progressing to surgery based on the Cobb angle and that period of maximum progression. In girls with a Cobb angle of 30 degrees or less at that peak height velocity, only 4% will progress to surgery. However, with Cobb angles above 30 at that peak height velocity, that jumps up to 83%. And the numbers are even worse for boys. In boys with a Cobb angle below 30 at peak height velocity, 14% will progress to surgery, whereas if the Cobb is above 30 degrees, 100% of them will progress to surgery. Now, this is not saying that surgery is necessarily your destiny, it just means that they progress to the threshold for which surgery is recommended. This next slide looks at the predictability of the timing of that period of maximum progression based on your Sanders stage. At the bottom of the chart, there's a lot of variability, but once you get to a Sanders stage 3A or 3B, these data points are very tightly packed, and that's that period of maximum progression, so we know that a Sanders stage 3 is very closely related to that peak height velocity or that growth spurt. This next slide is Dr. Manuel Rigo talking about what makes a good brace. One of the things he noted is that a good brace must decrease the oblique diameter of the rib cage. You can see how much smaller the oblique diameter of the rib cage is on that good brace on the right side. Another part to note is that counterforces on the ventral aspect of the brace are necessary in order to avoid lorditization of the thoracic spine. Basically, you don't want your thoracic spine to move from a curved to a flattened position, which is part of the normal progression with scoliosis. You certainly don't want your brace to make things worse. One of the things that Dr. Rigo mentioned when he was asked about how to control proximal curves, which is in the higher thoracic or lower cervical region, especially with bracing, he said, "I have no idea." So I'm sorry to you guys out there who have a proximal curve. Right now we really don't have a good handle on how to control those with braces, or even Stroth exercises for that matter. This next slide is talking about earlier bracing interventions for juvenile scoliosis. The results are pretty intuitive. The earlier you start bracing, the better the outcomes will be. And what they found was bracing in those patients led to stabilization in 49% of curves and improvement in 22% of curves. Again, it's kind of intuitive, but the earlier you start bracing, the better the outcomes will be. This next study expanded on the bracing protocols for juveniles with scoliosis. Specifically, they were looking at only part-time bracing. The protocol is laid out here in this image. What they did was take a group who did not brace and a group who did part-time bracing. The group who did not brace was 2.5 more times likely to progress greater than 5 degrees. They were 2.7 times more likely to have a Cobb angle greater than 25 degrees, and they were 3.4 times more likely of converting to full-time bracing at some point in their development. Overall, what they found was that kids who were even just doing part-time bracing were 3.3 times more likely to reduce their curve by greater than 5 degrees. So this is telling us that for juveniles with scoliosis, they may not even need the full-time brace. Even if they're only doing it part-time, they can still reap the benefits. This next study was looking at brace compliance. Again, the results are not very shocking, but what they found was that patients who thought they were being monitored were more compliant with their brace. And among kids who did progress to surgery with scoliosis, they were less likely to have been compliant with their bracing protocols. He also mentioned this number of 48%, which is the percentage of correction you should expect in the brace with adolescent idiopathic scoliosis. And you can expect even more than that for juveniles because they're typically younger and more malleable. This next presentation was by an orthotist that I've personally worked closely with, Stephanie Romero from the Align Clinic. She was talking about the indications for adult bracing. What she determined was that adult bracing usually has a positive short-term effect on pain, posture, and reducing the progression of the curve. Not everyone is a good candidate for adult bracing, but what she found was that the best candidates are people whose ADLs and recreational activities are negatively impacted by pain, and when they do their exercises and are compliant with the bracing, they have reduced pain. This next presenter was talking about Ehlers-Danlos syndrome and hypermobility disorders related to scoliosis. One of the common practices we utilize in Schroth therapy and physical therapy of all types is traction and elongation. If someone has joints that are already loose and already hypermobile, the last thing you want to do is stretch them out anymore. This slide kind of lays out some red flags, some yellow flags, and some green flags for when you should or should not use traction. You can pause here if you need to see more. For those who have hypermobility disorders, the treatment should focus on stabilization rather than mobility. This last presenter talked about prehab for adult spinal surgery candidates. There is a lower economic burden for those who go through prehab because they have less doctor's visits and less imaging from their follow-ups. There's an understanding involved and they're not quite as worried about pain or discomfort. They have found that prehab results in less post-operative pain at 3 and 6 months checkups. So that's my summary of the 9th Annual Pediatric Spine Symposium. One of the consistent themes here is that earlier treatment and more treatment for scoliosis typically leads to better outcomes. There's been an overall pushback in the medical community to not overprescribe and overtreat things and impose a higher economic demand. But with scoliosis, it seems we may have taken that a little bit too far. We have been withholding treatment from people who could actually benefit from earlier treatment. And ultimately, that leads to a lower economic burden. A brace certainly costs much less than a spinal fusion. I hope you guys find this information valuable. Feel free to drop questions or comments down below, and I'll have more coming soon.